The present topic of discussion, it is on bacterial infections, which are also chronic inflammatory conditions or granulomatous infections also you can say. So here we will be discussing about the most important ones of these bacterial infections. So first and foremost we shall be discussing about tuberculosis. Tuberculosis, it is caused by a bacilli called as Mycobacterium tuberculosis, which most commonly affects the lungs. And this tuberculosis, as I told you already, these are chronic granulomatous inflammatory diseases. That means these are inflammatory diseases which produce numerous granulomas during the pathogenesis of the lesion. Okay, so if you see the etiology of tuberculosis, as I already told you, that it is caused by Mycobacterium tuberculosis. So that is the main bacilli which is responsible for the causation of tuberculosis, and this is a picture of those bacilli. So as I am saying bacilli, so they are rod shaped, aerobic in nature, and they are non-spore forming bacteria. And these bacilli, they contain a thick waxy cell wall, thick waxy coating on their surface. So this thick waxy coating, it is a fatty acid or a lipid which is nothing but mycolic acid. What is the importance of this mycolic acid is that to stain this tuberculosis bacilli, we use a stain called as acid fast stain. So during this stain there is a decolorizer called as 20% sulfuric acid. So this mycolic acid, it resists decolorization with 20% sulfuric acid. That is why it is called as acid fast bacillus, because it resists decolorization with the decolorizer sulfuric acid. So other than this name acid fast bacillus, this also has another name called as Koch's bacillus. Why? Because it was described by Robert Koch in 1882. This is in general about etiology about tuberculosis. Now let's see the pathogenesis of tuberculosis. How does tuberculosis occurs? Usually this tuberculosis occurs by the interaction of the bacilli and the host through some droplet infection, as you can see in the picture. So because of these droplets they enter the nose. So nose is lined by mucosa, that is a ciliated epithelium. So these cilia it entraps most of the bacilli and it will be thrown out or it will destroy them. But out of these most bacilli, some 10% of the bacilli, they escape the ciliary route and they enter the lungs, that is they enter the alveoli of the lungs. So when they enter the alveoli of the lungs, they contain some cells called as macrophages, which are dendritic cells or antigen presenting cells. As you can see in this picture, in the alveoli we have alveolar macrophages where they entrap these bacilli. Okay, and they will want to kill the bacilli, but they will not be able to because of the improper fusion of the endosome and the phagolysosome. So what happens is that these bacilli, they have the advantage and they will start to multiply inside these alveolar macrophages only. So now as alveolar macrophages, they are not able to destroy this bacilli. So what they will do is they will travel to the lymph nodes, that is after 3 weeks they will see, and they will travel to the nearby lymph nodes. So nearby lymph nodes for the lungs, it is all these hilar lymph nodes and all. Okay, so in the lymph nodes there will be CD4 plus T cells which are naive, that is inactive T cells. To these inactive T cells are alveolar macrophages, they will give the bacilli to them. So when giving the bacilli to them, they will even secrete a cytokine called as interleukin 12, so that it will help in the activation of the T lymphocytes. And now that these T lymphocytes, that is T cells, they will secrete another cytokine called as interferon gamma. So what this cytokine will do is it will recruit more and more monocytes or macrophages from the bone marrow. So now that we have T lymphocytes and we have more macrophages, and these macrophages, what they will do is they will undergo modification to become epithelioid cells, epithelioid macrophages. So these epithelioid macrophages, as they are not able to kill these bacilli, what they will do is like they will start to fuse together to form a giant cell, so that like they can kill the bacteria. Okay, so now we have T lymphocytes, we have epithelioid macrophages and some giant cells, right? So these giant cells will be either Langhans type giant cell or foreign body giant cells. So all this together is called as hard tubercle. But whenever in the center of this hard tubercle, if we see some caseation necrosis, then it is called as soft tubercle, and this is all is called as granuloma formation, which is the main pathogenesis of tuberculosis. So now if we see clinical features of tuberculosis, usually it will be pulmonary or extrapulmonary in nature, and under pulmonary tuberculosis we have primary or post-primary or secondary tuberculosis. If you see primary tuberculosis, this usually occurs in children. Okay, that is why it is called as childhood tuberculosis also. And the most commonly involved tissues in this primary tuberculosis are lungs and the hilar lymph nodes. And this primary complex is called as Gons complex. Okay, so once this primary tuberculosis is formed, depending upon the host immunity, the fate of the primary tuberculosis will be there. So if the host is having low immunity, then there will be spread to other organs, which is called as miliary tuberculosis. So other organs will be liver, spleen, kidney, brain and bone marrow. But if the host is having good immunity, what happens is that this primary tuberculosis will not progress, and instead it will heal by fibrosis, and sometimes it might even undergo calcification and even ossification also. But during this process, if there is again decreased immunity, there can be reactivation or reinfection of this primary tuberculosis, resulting in progressive secondary tuberculosis. So now let's see symptoms. What all the symptoms will be there in different types of tuberculosis. So if you see in primary tuberculosis, it is usually asymptomatic in nature. Only mild illness and cough will be there, and that cough will be dry and productive cough. Whereas secondary tuberculosis will show fever, cough and chest pain, and miliary tuberculosis wherein there will be very ill health, anorexia, weight loss and fever will be there. And if you see other symptoms, the most commonly tuberculosis, it will infect the lymph nodes nearby. So most commonly submandibular and cervical lymph nodes are involved, resulting in tuberculous lymphadenitis, which is also called as scrofula. So here if you see the site of that lymph nodes, they are tender, they are inflamed overlying skin will be there, sometimes which can perforate and discharge pus also. Okay, so this is called as scrofula or tuberculous lymphadenitis. If at all tuberculosis occurs on skin, in relation to skin, then it is called as lupus vulgaris, wherein we will see nodules which frequently ulcerate. And if you see oral manifestations of these tuberculosis, so this is an oral tuberculosis ulcer, which is very painful ulcer, and the ulcers will have irregular borders. Okay, so irregular, superficial or deep painful ulcers will be there. And the second picture and the third picture, it shows tuberculous gingivitis, wherein gingiva are involved. So what gingiva will be, they will be very much hyperemic, that is reddish in nature, and sometimes they might be nodular or papillary proliferation of these gingival tissues. And if at all this tuberculosis, it involves the periapical area of the teeth, that is if at all tuberculous periapical granuloma occurs, then it is called as tuberculoma. And sometimes there will be diffuse involvement of maxilla and mandible may occur by the way of hematogenous spread. This kind of hematogenous spread to enter maxilla or mandible is called as tuberculous osteomyelitis. So these are the various oral manifestations which are seen in tuberculosis. Now let's see, how do we diagnose, how do we demonstrate Mycobacterium tuberculous bacteria. First is culture media. The main important culture media what we can use are LJ medium, that is Lowenstein-Janssen medium, and Middlebrook medium. If you see in case of Lowenstein-Jensen, this picture is of LJ medium only, wherein the green color of the medium is because of the malachite green. And here the organisms will be non-pigmented, rough and dry colonies will be there. And there are some special stains which can be used to demonstrate Mycobacterium tuberculosis, that is Ziehl-Neelsen stain, which is also called as acid-fast staining. Kinyon's cold staining, it is a modification of Ziehl-Neelsen stain. And there is rhodamin staining which can be seen under fluorescent microscopy. And this picture is of acid-fast staining, wherein those long pink rods, they are nothing but our Mycobacterium tuberculosis upon Ziehl-Neelsen stain. And this third picture, it is rhodamin staining under fluorescent microscopy, wherein those fluorescing rods are nothing but Mycobacterium tuberculosis rods. So if we take a biopsy of this tuberculous lesion, then we under histopathology we will see a granuloma. So this picture is of a granuloma. That entire thing is a granuloma, where you can see some multinucleated giant cells in the center. So this represents, that is one Langhans giant cell, wherein towards the poles, that is horseshoe shaped nuclei are there, and some pale stained cells are there in between. Those are nothing but epithelioid macrophages. And peripherally we will see some lymphocytes. So that is about tuberculosis. Now let's see about leprosy. Leprosy, it is also called as Hansen's disease. It is a chronic leprosy. It is also called as Hansen's disease. Sorry, it is a chronic granulomatous infection which is caused by Mycobacterium leprae. So this Mycobacterium leprae, it is a acid-fast bacillus again. And if you see, like it is the only bacterium which has a predilection towards peripheral nerves. So this is very important, that it has predilection towards peripheral nerves, and it also has affinity to colder regions like upper respiratory tract, anterior chamber of the eye, axilla, groin, scalp, all these. Okay. So now let's see the pathogenesis of leprosy. How does the leprosy occurs? Okay, if you see here, bacilli which are discharged from the nose of an infected person. So if these bacilli, they are inhaled by another person, so then they will enter through the nose and they will be taken up by the alveolar macrophages. From there it will be disseminated through the blood. As I already told you, it has a predilection to peripheral nerves, so it spreads to nerve and skin, and the bacilli proliferate within the Schwann cells, which are nerve cells. So while I am telling you this, as alveolar macrophages are taking up the bacilli, why is this alveolar macrophages not killing the bacilli? Why? Because in the cell wall of the leprae bacilli, they contain lipoarabiminin, which causes immune suppression. That is, by inhibiting interferon gamma activation of the macrophages, they are producing immune suppression. That is why this bacilli, they only replicate but they won't die within the macrophages. Okay. And depending upon the immune response, there are different types of classifications given. That is, if the host is having a good immunity, then it is called as a tuberculoid pole. If the person is having a low immunity, that is low resistance to the bacilli, then it is lepromatous pole. And in between them we have borderline tuberculoid, mid borderline, and borderline lepromatous. So these are the various types. So in this discussion we will be discussing the high resistance one and the low resistance one under clinical features. So let's see the high resistance one, that is tuberculoid polar, that is paucibacillary leprosy. So this paucibacillary leprosy, pauci means less number of bacilli, so it corresponds to tuberculoid pattern of leprosy, and here it contains well circumscribed hypopigmented skin lesions. As I told you, it involves peripheral nerves, so it results in anesthesia of the affected skin and loss of sweating. And the opposite of paucibacillary leprosy is multibacillary leprosy, so that corresponds to lepromatous pattern of leprosy. So here what happens is there will be numerous ill-defined hypopigmented macules will be there. So macules will be there, later on papules will be seen, and then in the time, as the time progresses, these papules, they will become thickened to form nodules. So in multibacillary leprosy, because of high number of bacilli, we'll see macules, papules as well as nodules also. And other than this, there will be facial paralysis also because of the facial nerve involvement. And as the face is involved, there will be, because of numerous skin, and that is numerous nodules which can be seen, it results in distorted facial appearance. That distorted facial appearance is called as leonine facies. Okay. And if you see oral manifestations, there will be small tumor like masses, as you can see in this picture. These are called as lepromas, that can develop on tongue, lips or hard palate. Okay, as you can see here, a leproma has developed on the hard palate of a leprosy patient. And there is a complex which is called as odontodysplasia leprosa, wherein there will be premaxilla which is affected during the childhood due to granulomatous involvement, and along with that there will be circumferential hypoplasia as well as shortening of the roots of the teeth, which can be seen mostly in the maxillary anterior teeth. These are the various clinical features which are seen in leprosy. So now how do we demonstrate leprosy? So main important stain is Phyte Farraco stain. So this is a Phyte Farraco stain which is used to stain a leprosy tissue, wherein the lepra bacilli, that is those pink dotty areas are there, those are nothing but lepra bacilli. They are seen as globi or cigarettes in a pack appearance inside the foamy macrophages. All that blue background different cells are there, those are foamy macrophages. And if you take a biopsy of this and stain with hematoxylin and eosin, we will see a granuloma like this, like in case of tuberculosis only, where we will see numerous lymphocytes with vacuolated histiocytes known as lepra cells. So if we take a smear from the lesional site and stain with acid fast stain, then also we can demonstrate this lepra bacilli. Here also we can use acid fast stain, which is also called as Ziehl-Neelsen stain. So this is about leprosy. Now let's move into the next bacterial infection, that is syphilis, which is a venereal disease or also a sexually transmitted disease that is caused by a bacilli called caused by a bacteria called Treponema pallidum, which is a spirochete. That means it is a coiled bacteria. It is a thin coiled bacteria. As you can see in this picture, this is a picture of a Treponema pallidum, which is a thin coiled bacteria, and it is motile in nature. Okay. And how does this syphilis is transmitted from one person to another person, as these are contagious diseases? So the mode of transmission is by three routes. One is sexual intercourse or transfusion of infected by, or from mother to child, that is materno-fetal transmission. So let's see the pathogenesis of syphilis. So while discussing pathogenesis itself, we will discuss about the clinical features. And if you see, there are in syphilis there are three stages, that is primary, secondary and tertiary syphilis. So let's discuss the pathogenesis as well as the clinical features of all the three stages. So whenever there is any contact with a partner infected with the syphilis, there will be attachment of the bacilli at the inoculated site, resulting in primary syphilis. And the lesion in primary syphilis is called as chancre. And this chancre, most of the times it will be solitary only, very sometimes it will be like multiple, and most commonly it involves genitals, but if at all it is involving the oral cavity. So this is a picture of chancre of tongue, wherein it is an elevated ulcerated nodule which shows induration, that is hardness. And wherever it is showing these features, that is chancre features, there will be regional lymphadenitis also. Okay, so it after 6 weeks there will be invasion of this bacteria, resulting in secondary syphilis, wherein here the characteristic feature in the oral cavity is a mucus patch. So here these are multiple, not like chancre which is solitary. So they are multiple, and these are painless, and greyish white plaques will appear sometimes upon the ulcerated surface. So these are mucus patches. And the second symptom is split papules, as you can see near the crease of the oral commissure. So these are elevated mucus patches which are seen near the oral commissure. So these are called as split papules. So there is one more feature which is seen in secondary syphilis, that is papillary lesions. So that is a tongue wherein some papillary lesions are seen on the surface of the tongue which resembles viral papillomas. Okay, so this lesion is called as condyloma lata. So this mucus patch, split papule and condyloma lata, these are seen in secondary syphilis. And this secondary syphilis, it is a highly contagious stage, and it is highly infectious stage, and it is serologically positive because of the multiplication of the bacilli here. And there is a widely explosive form of the secondary syphilis called as Louis maligna is seen. And when the bacilli multiplies and then after years it shows syphilis called as tertiary syphilis, which is also called as late syphilis, wherein it chiefly involves cardiovascular system and the central nervous system. And here the manifestation or the classic lesion of the tertiary syphilis will be in the form of a gamma. Okay, and this gamma, it results because of a hypersensitivity reaction between the host and the treponema bacterium or its breakdown products. So what will be the features in the tertiary syphilis? So if you see this picture, so it is a gummatous lesion of the tongue wherein large lobulated and irregularly shaped lesion is formed on the lateral border of the tongue. This lobulated pattern is called as interstitial glossitis. And sometimes there will be atrophy and loss of the dorsal tongue papilla also can be seen, which is called as lutic glossitis or atrophic glossitis. Why this lutic glossitis is important is because it is considered as a precancerous lesion. Okay, and other than this, sometimes there can be involvement of the palate wherein there can be ulceration which can be produced, wherein this ulceration proceeds resulting in a perforation through the hard palate. So these are the various features seen in different types of syphilis. And now let's see another form of syphilis, which is congenital syphilis, which is because of transmission from an infected mother to the offspring. And what are all the features which are seen in infants in congenital syphilis? It is frontal bossing, short maxilla, saddle nose deformity, high palatal arch and mulberry molars. Along with this, there will be a sign called as Hygomenakis sign, which is nothing but it is irregular thickening of the clavicle, sternoclavicular portion of the clavicle. So along with Hygomenakis sign, there will be protuberance of the mandible also can be seen, raggeds can be seen, and saber shin can be seen. And there is a pathognomonic feature of congenital syphilis, that is Hutchinson's triad. That means there will be three different lesions, that is hypoplasia of incisors and molars will be there, eighth nerve deafness will be there, and interstitial keratitis. All these three, they constitute Hutchinson's triad that is seen in congenital syphilis. So now we will move into demonstration or diagnosis of syphilis. How do we demonstrate treponema pallidum? First is by dark ground elimination, wherein here we will demonstrate the spiral organisms. As you can see under the dark background, these spiral that is coiled spirochetes, they will appear self-luminated within dark ground illumination. And the next investigation is serological test, wherein these serological tests are of two types, non-treponemal test and treponemal test. Under non-treponemal test, we have a VDRL test, that is venereal disease research laboratory test. And under treponemal test, we have three different, that is TPI test, treponema pallidum immobilization test. We have fluorescent treponemal antibody observed test, that is FTA-ABS tests we have. And the third one is treponema pallidum's passive hemagglutination test, okay, TPHA test. So these are the specific tests, that is treponemal serological tests are specific tests for treponema pallidum alone. So this is about syphilis. Now let's move into another disease, that is actinomycosis, and now this is not contagious like the other three. Okay, so actinomycosis, which is caused by an anaerobic bacteria, that is Actinomyces israeli, which is a gram positive filamentous bacteria. Okay, and if we see pathogenesis, as I already told you, it is not a contagious disease, so it cannot be transmitted from one individual to other. So how does this actinomycosis causes is because of any prior trauma, surgery, or any previous infection. So if you take oral cavity, if there is any site of tooth extraction or any gingival surgery or any oral infection, they cause an opening, or they cause an barrier. They remove the barrier for the actinomyces to enter into the tissues. So the organism, it typically enters through these areas of trauma, and then it starts to directly extend into the soft tissues. So it doesn't follow any tissue planes. Here it starts to whatever comes in between, either lymph nodes or salivary glands or any muscle, anything, it starts to directly extend through the soft tissues, and the infection, it spreads to the surface through a sinus tract. As it is spreading through the sinus tract, there will be pus drainage which will occur there. Okay, that is in the form of an abscess. So if you take this pus and observe it on a clean glass slide under the microscope, they appear as typical sulfur granules, or these are nothing but colonies of organisms only. So this is pathognomonic of actinomycosis, that is sulfur granules or colonies of organisms. So if you see clinical features of actinomycosis, based upon the anatomical location, there are different types of actinomycosis, that is cervicofacial, thoracic, abdominal, and pelvic. If you see cervicofacial actinomycosis, it is a majorly occurring form. It constitutes the major occurring form among all others. Here what happens is that it causes swelling and induration of the tissue where it has caused the lesion. As you can see in this present picture, there is a swelling, and if you touch it, it will give that hard appearance. That is why it is indurated. So this area over the skin, over the abscess, it is purplish red in color, and it is indurated. That is, it has the feel of wood, or sometimes it can be even fluctuant also. And here there will be a sinus which is formed, as you can see that yellow portion, through which abscess will be drained. Okay, and sometimes as it is infecting the soft tissues, it may even extend into the mandible or maxilla, that is bone may be infected, resulting in actinomycotic osteomyelitis. And the next form is thoracic actinomycosis, wherein there will be aspiration of organism from the oral cavity into the abdominal region, wherein this thoracic actinomycosis will resemble pneumonia. Okay, next is abdominal actinomycosis. Here it is commonly seen in appendix, cecum, or in liver. Okay, and this is also, it is followed by swallowing of the organisms from the oral cavity or by direct extension. Pelvic actinomycosis, infection in the pelvis, it can occur as a complication of intrauterine contraceptive devices. So these are the various forms of actinomycosis. Now let's see histologic features. As if we take any biopsy of the lesion and see it under the microscope, it will appear like a granulomatous inflammation only. Okay, wherein there will be central abscess formation will be there with the colonies of microorganisms. As you can see this picture here, so that is one colony of microorganisms with surrounding inflammatory cells. Here the inflammatory cells will be neutrophils, and that is one colony of organism wherein individual colony will appear round or lobulated in appearance. So colonies are surrounded by neutrophils, as I told you, and each colony will be round or lobulated. And if you see, they contain centrally, if you see, there is hematoxyphilic, and peripherally there is eosinophilic rod shaped or club shaped filaments. So this central hematoxyphilic meshwork of filaments and peripheral club shaped ends of filaments which are eosinophilic in nature. So altogether that radiating filamentous nature is there, right? So that is why this actinomycosis is called as ray fungus. Okay, and other than these this H&E staining of biopsy, we can even culture this actinomyces israeli. So what are the various culture media we used are, solid media is brain heart infusion agar, wherein actinomyces appears as small spidery colonies, whereas liquid media is thioglycolate media, wherein it appears as fluffy balls at the bottom of the tube. And there is one more solid agar, media, that is blood agar, wherein actinomyces appears as molar tooth shaped colonies. So this is about actinomycosis, and this is the end of these bacterial infections. I mean, we have discussed the most important of the bacterial infections, that is tuberculosis, leprosy, syphilis, as well as actinomycosis. So mostly if you take in exam point of view, they will come as short notes mostly, that is either demonstration or like clinical features, something like that.